So what I'm going to discuss here, of course, we're going to revise pathology in 1 hour. That is what is my first aim. And more important than that, I want to start with something else, which many of the students, I have seen this happening again and again. People asking me these questions. Just a minute, I have to just cross check. Yeah. So from my side, audio video is all fine. Yes. Good evening. So what I'm going to discuss here is, first how to approach a clinical vignette. This is a very trick I keep giving always. I keep answering so many students about this. So in general, this will be for any subject. Need not be my subject. I would always say this is for any subject. Let me start with this. So what I would like to do. So whenever you see a question, a lengthy question. So what is my approach? So my approach would be the following should be in the order. So I should start looking at following order. You make a habit of reading it in the following order itself, I would say. So any question, any lengthy question you get, start making a habit of looking this in following order. The first thing I will look at is jump over to the last line of the question. So, which of the following is the next investigation, which of the following is the best treatment, which will be the, most likely diagnosis, or which pathology is most likely to be seen in this patient. So whatever has been given, I will look at that. After this, my next look will be options. See, always make options. There are there are always two ways. Options either will be your friends or will be your foes in exam. If they are your foes, God help you. If you make them with friendship with your options, you are going to, use them to your advantage. Options are like 4 hints given to me. Remember in your vivas, whenever you just stopped somewhere, your internal examiner used to, give some hints to you. That is what is option doing, by the way. So look at options. Audio is not there. Just a minute. I think from my side, audio is okay. We said, please check audio. God help you if you make them with friendship with your options. No, audio is there from my side. I checked it again. Even in my mobile as well, I checked it. So I think somewhere you have muted yourself. Please check that. Okay. Then third one will be image. So, whenever if image is given. So, image, I would like to keep it, alternate. Maybe image first, options first, or options first, image first, either of them. It depends upon, like for example, ECG is given. I would always like to, go for ECG, or radiology is given. That might give me more hint. So I would like to go with that option or image, either of them. So 2 and 3. And once I do this, so what will I do is, without even looking at the clinical history of the patient, I will make a sense of what examiner is expecting from me. Say, for example, there is a question asked, there's an image of a kidney tumor, and examiner is asking something. Yes. So just a minute. I'll just check. There is some voice disturbance. Okay, so that is how I would like to go with. So image, make a sense what examiner is asking you to differentiate or anything like that. So once you know what examiner is expecting you to differentiate, then you will start looking at the keywords. So keywords, always we keep telling keywords always will be in retrospect, not in a prospect. So retrospectively, yeah. So retrospectively, when I look at the keywords, so when I look at the keywords, always the keywords will be based on what examiner is asking. So then you will end up picking up the keywords. So this is what will be your order of answering any question. So order of answering any question will be these. And once you do this, then you arrive at the diagnosis easily. So how to identify keyword? Keyword will always be dependent on what examiner is trying to differentiate between you or asking between you. So basically that is how the keyword is going to work for you. So keywords in retrospect, you should be in a position to identify. Prospectively, I'll be giving you lots of keywords from general pathology, from systemic pathology, etc. So then we'll start understanding things easily. So clinical vignettes, I'll start with revision based on the keywords. So my revision is keywords. That is, the keyword is my theme for this must know topics. So what I'll be doing is I only keep looking at the keywords. So keywords could be a word, it could be clinical word, it could be a lab investigation, it could be even image as well for me. So first I will start with the clinical manifestation of a keyword. Yes, recurrent infection. That is one of them. So recurrent infection, and especially this is a keyword that's going to come. Clinical vignettes are going to come from general pathology here, right? Yes. So, recurrent infection could be two possibilities, inherited or maybe acquired as well. So, if it is inherited, we are suspecting of immunodeficiency disorders, the primary immunodeficiency disorders, or might be an acquired condition altogether. So, acquired condition, common ones are, leukemia, lymphomas will have, acquired immunodeficiency happening because bone marrow suppression will be happening. Multiple myeloma will have that. Then other than that, HIV, AIDS can have, drugs can have, like immunosuppressive drugs, maybe steroids, or even malignancies which can metastasize to bone marrow can lead to immunosuppression as well. So acquired one, we are not interested in the acquired one here. Yes, so we are interested in the inherited one. So in inherited, there will be no much clinical hint given. In acquired, there will be adequate clinical hint for lymphoma, leukemia, myelomas, or HIV, AIDS, immunosuppressive, other malignancies also. I told you the acquired could be there, right? Yes. Now, the primary immunodeficiency disorders I am discussing now. So the primary immunodeficiency will be having no much, what do you call clinical hints given to you, although there are some subtle hints. So we are discussing recurrent infection in a child. So basically, when I am suspecting in a child, I am suspecting a primary immunodeficiency here, right? I am suspecting a primary immunodeficiency. There are many primary immunodeficiency disorders, and all of them will have recurrent infections. So very important, I start looking at keywords here. So how will the question be? They would have given a lengthy question. The last question will be, what will be your diagnosis? And 4 options, you look at it, it will have an immunodeficiency disorder. The moment you see that, then what you now understand, it's an immunodeficiency disorder. Do you want to look at what, is there a recurrent infection or no recurrent infection, or a child, what age? No. So now here automatically the keywords should strike for your immunodeficiency disorders, the primary immunodeficiency disorders. So primary immunodeficiency disorder, recurrent infection with bleeding could be there. So with bleeding manifestation is one of them. So they would have given you umbilical cord bleeding is there, recurrent infection is also happening, patient is having hemarthrosis, etc., or any bleeding manifestation. So we can suspect 2 of them. So check for the platelet count in the patient. Platelet count in the patient, you have to check 2 or 3 DDs are there for me. So check for platelet count in the patient. It would be given if it is reduced or normal. If it is reduced platelet count, I only have one diagnosis, one DD here, or one diagnosis, Wiskott-Aldrich syndrome. If you remember, Wiskott-Aldrich syndrome will present with a triad of eczema, recurrent infection, and thrombocytopenia, which will have bleeding manifestation, by the way, right? So if it is a normal, so platelet count are normal, that means there will be a functional disorder of the platelet happening. It could be either LAD, leukocyte adhesion molecule deficiency, especially a type 3 LAD, which is associated with Glanzmann thrombasthenia, if you remember. So this will have a delayed healing, of course, delayed umbilical cord bleeding. Important, LADs will have neutrophilia, very important word. So whenever you have a normal platelet count, look at the neutrophil count. If it is a neutrophilia is there, then what will be your DD you are suspecting? So you are suspecting a LAD, which will have a normal platelet count, but functional disorder will be there. Type 3 LAD is associated with Glanzmann thrombasthenia, GP2B3A deficiency. So, examiner can ask this. Then next, one more is Chediak-Higashi syndrome. Whatever you can write. Otherwise, I'll be giving this PDF. Don't worry about this. Chediak-Higashi syndrome, very important. Chediak-Higashi syndrome, there will be defect in the platelet granules, and that is why this will also present with bleeding manifestation. Sometimes very mild bleeding, but yes, bleeding can be there. Important, associated albinism. Look for this word albinism associated with, then makes a diagnosis of Chediak-Higashi. So now look how examiner will give you. Basically, examiner will give you a recurrent infection. Patient is also having increased petechia, purpura, etc. Platelet count is less, then make a diagnosis of, Wiskott-Aldrich. Platelet count is normal, neutrophil count is more. Start making a diagnosis of LAD, or maybe sometimes LAD is associated with Bombay blood group. They might give you that as well, but type 2 is associated, and then or albinism they can be giving. So basically, the same clinical vignette with slightly changed clinical features will make differential diagnosis. This is how examiner will think when he is making a question. That's what I'm trying to give you. Next, One more situation would be your recurrent infection with allergic manifestation. So patients will be having recurrent infection. He's also having eczema, or he's having anaphylaxis or any other allergic manifestations. So one allergic manifestation, already eczema, I told you, can be associated with recurrent, Wiskott-Aldrich syndrome. Thrombocytopenia will be there. So check for platelet count. That will help you out. The other way around is one more, check for IgA levels. IgA levels would have been given. IgA levels are increased and allergic manifestations are there. IgA levels are increased. Then it is again a Wiskott-Aldrich syndrome. IgA levels are increased, Wiskott-Aldrich syndrome. IgA levels are reduced, then it's a isolated IgA deficiency. So very important, allergic recurrent infection with allergy, two important causes, isolated IgA deficiency and a Wiskott-Aldrich. How do I differentiate between them? Levels of IgA. IgA will be more in Wiskott-Aldrich, IgA will be less in isolated IgA deficiency. Even you can check IgM. IgM will be low in Wiskott-Aldrich, IgM will be normal in IgA deficiency. IgM. IgG will be normal in both of them. Do not check for IgG. Examiner will keep giving you these things. Don't use them. Use always the keywords here. Next, one more recurrent infection. I would like to go with only catalase positive organism. Organism specific infection, only one diagnosis. There is no DD here. Only catalase positive, like staphylococcal infection. Consider the diagnosis chronic granulomatous disease, CGD, which is occurring due to NADPH oxidase deficiency, right? That is what you will look at. Next, audio video, everything is clear. I think video you have to adjust your quality of the video already will be in auto mode. Just click on the right hand top corner, there is setting button. You can go and shift to your better audio quality. Next, recurrent infection with clinically very small and shrunken B lymphoid organs like lymph node and spleen. So shrunken lymph node, shrunken spleen, basically that means B cells are not produced. That's why there is no becoming into plasma cell there, right? That is why no enlarge or no development of these organs. So then I will check for the B and the T cells here. So check for peripheral blood B and T cells. In the peripheral blood, absent B cells only or absent both of them. So if it is only B cell absent, then it is only a primary humoral immunodeficiency disorder. I am going to think of a Bruton's A gamma globulinemia or X-linked A gamma globulinemia here. So Bruton will have recurrent infection, small shrunken lymph node, spleen, and peripheral blood will have absence of B cell. Of course, all immunoglobulins will be absent. That also is one more hint they can be giving you. Yes. Absent both B and T cells. So if both B and T cells are absent and shrunken lymph node is there, this will be your SCID. SCID, severe combined immunodeficiency disorder. In severe combined immunodeficiency, there is failure of proliferation of the lymphoid stem cells. So no B cells, no T cells, both of them are reduced. That is why less B cells or no B cells, no maturation to plasma cell. That's why no immunoglobulin production. All immunoglobulins will be reduced here as well. So very important, all immunoglobulin reduced in both the conditions. So that will not differentiate. All immunoglobulins will be reduced in both of them. So very important, both B and T cells are reduced. That means lymphocytes are less. Whereas in case of Bruton's, there was only lymphocyte is less. B lymphocyte is less. Then the last one, I will think of small or atrophied thymus. So if there is a small or atrophied thymus along with small and shrunken lymph node, then I will think of SCID. So small lymph node, shrunken lymph node, small both B lymphoid organ and T lymphoid organ, recurrent infection, SCID I will think of, right? So if only thymus is small, lymph node, spleen, everything is normal, immunoglobulin levels are normal, that is what they will give you as a hint, then check for if the child is having hypocalcemia. Hypocalcemia usually manifests with tetany and seizures in childhood. So hypocalcemia, tetany and seizures, or even look for cleft palate, then congenital heart diseases. If any one of them is there, yes, correct, this will be a Digeot syndrome. So this is how you approach. Now look at this. That is why I always say clinical vignettes, examiner can keep twisting you. A subtle change and the whole question ends up twisting. So patient recurrent infection, all immunoglobulins are reduced and T cells are normal in the peripheral blood, absent B cell. I will start thinking of a Bruton's. Both B and T cells are reduced in the peripheral blood. All immunoglobulins are reduced. Now don't look for the wrong clue or the wrong keyword. Immunoglobulin reduced doesn't mean it is only a Brutans, it can even be SCID. Even in SCID, all immunoglobulins are reduced. So that's why very important, look for both B and T cells or only T cells. So this is how I look at, different disorders of recurrent infection. Basically, the acquired one will be quite easy for you because you will end up having adequate clinical history there. Like HIV, myeloma, etc. We'll discuss them as and when they come here, right? So this is one very important clinical vignette. For sure, question will come from here because lots of twists and turns in the question can be there in this. So that's the first one I wanted to discuss. Next, one more from immunology I wanted to discuss is, immune complex mediated disease like a serum sickness, and which is frequently confused many a times with tumor lysis syndrome. So what is happening in a serum sickness disease? Basically, serum sickness disease is an immune complex mediated whenever you give any antibodies to you, and these antibodies are also foreign antigens. Basically, they are non-self for me. I might mount an antibody against this antibody and they form immune complex, and immune complex disease can get settled anywhere in circulating immune complex. So generalized manifestation. Serum sickness will have a generalized manifestation, and so is your tumor lysis syndrome. Tumor lysis syndrome happens whenever you are giving anti-tumor therapy. Now, sir, why are they coming as a DD? Because again, tumor lysis syndrome will have, multiple generalized manifestation. Sir, why are they coming as a DD? Because one of the common cause of serum sickness is anti-tumor drugs like a monoclonal antibodies. That is when you start confusing. Both of them will have generalized manifestation. Both of them will have high grade fever, hematuria, renal failure manifestation, or lymphadenopathy, ulceration, any generalized manifestation can be in both of them. So how do I differentiate? So let me tell you, for serum sickness, after monoclonal antibodies, after anti-snake venom, it can occur after anti-snake venom, after anti-thymocyte immunoglobulins, or after anti-rabies, anti-hepatitis immunoglobulin, right? So basically, I'm talking these are the common causes. Earlier, serum sickness was because of horse's serum that has been injected into humans, right? So nowadays, we do not have that, but these are the common causes where serum sickness might happen, okay? Common clinical scenarios where we get a serum sickness. Whereas where do you get your tumor lysis syndrome? There will be after any anti-cancer drugs, especially very important for me, including the monoclonal antibodies. So this is where examiner will use the the gray area that is there. So he will give you a question. Patient is having a lymphoma. You started him on rituximab, and after starting rituximab, after 15 days, the patient presents to you with high grade fever, lymphadenopathy, maybe renal failure. Blood examination shows, phosphate is increased and some other things he might be giving you. And then what? You are now confused because it's a monoclonal antibody. It can cause serum sickness. It can even cause tumor lysis syndrome as well. And how do I differentiate? Very important keywords. Look for hyperuricemia, more in favor of tumor lysis syndrome. Hyperuricemia, more in case of tumor lysis. Hyperphosphatemia, only in tumor lysis syndrome. Hyperkalemia, only in tumor lysis syndrome. So all these three features will help me to differentiate hyperuricemia, hyperphosphatemia, hyperkalemia. Usually tumor lysis syndrome will have an acute renal failure happening, but that doesn't mean acute renal failure doesn't happen in a serum sickness, because serum sickness can cause a glomerulonephritis, and glomerulonephritis can lead to acute renal failure as well. So just to know that if they give you RBC CAS in the urine, that is more in favor of your serum sickness disease, right? So, that is how I will differentiate. So keywords, I already told you, these are my keywords. I look and I give you a typical example. They will give you any monoclonal antibody. It may be a trastuzumab, it may be, infliximab, it may be anything, by the way. So any monoclonal antibody, you can have two DDs, which are actually quite totally different in their mechanisms, but clinically sometimes end up, having similar things. That is why we look for these three things that will help me to differentiate. Right. So, these were two important clinical vignettes where I thought from, the inflammation immunity part of it. Now, next is I will go on to the neoplasia part in general pathology, and how do we get clinical vignettes in neoplasia. See, clinical vignettes in neoplasia, one could be a paraneoplastic syndrome. We all know paraneoplastic syndromes. We have ended up mugged it out many times. So we know the paraneoplastic syndromes. More important, I'm going to talk about is the inherited cancer syndromes. Inherited cancer syndrome. The video quality is good, by the way. Somebody is talking about video quality. From auto video quality, you shift it to high, you will automatically end up getting a very good quality of video, right? Yeah. So now I'm talking about the inherited cancer syndrome. This is a gold mine for examiner and a landmine for a student. So, I always say this: gold mine for examiner, because examiner can keep twisting n number of twists and turns I can give you. It is a landmine because you will end up falling trap every time for a student, right? Yes. Now, so inherited cancer syndromes. So inherited cancer syndromes, the first one, I will look at one keyword associated with GI polyps. So many inherited cancer syndromes have this GI polyps. So when I say GI polyp, examiner will give you, now look, how will the examiner give you? Any GI polyp, there can be a bleeding happening. So bleeding can manifest with a iron deficiency anemia. So examiner will start thinking about iron deficiency. The patient presented with hematologist with, easy fatigue and all those things, and microcytic hypochromic anemia. Iron studies have been done, shows, all suggestive of iron deficiency anemia. And then you have done a stool examination, and on the stool examination, you will get a occult stool blood positive, a colonoscopy was done, and a polyp was seen. After that, on detailed history, they will give you somebody else in their family was having all these manifestation. Then you will start thinking of it. So associated GI polyps, many of them. So it is, possibilities will be many. One is a FAP. First, let me list down things. FAP. What is FAP? Yes, familial adenomatous polyposis. Then there is a Gardner syndrome. Then there is a Turcot syndrome. Then there is a HNPCC or Lynch syndrome. Then you have, okay, let me just, start with this. What is this? FAP. FAP will have multiple adenomatous polyps and also will have history of cancer, colorectal carcinoma commonly. Multiple adenomatous polyps anywhere in the GIT, and history of colorectal carcinoma in first degree relatives. Gardner syndrome is FAP. Now look, very important, FAP plus osteomas plus dermoid, plus minus, you can write everything, and plus epidermoid cysts. So basically that is your Gardner syndrome. So examiner can give you a history like, okay, this would have been presented to orthopedician with a history of a bone tumor, and you're suspecting osteoma there. You ended up, routinely investigating before the surgery, and, you end up finding occult stool blood positive, a colonoscopy shows a polyp, and, then you ask for history, and there were multiple osteomas in somebody else in the family, start suspecting, yes, it could be a Gardner syndrome, right? Turcot syndrome. What is Turcot syndrome? Is also variant of FAP. FAP plus medulloblastoma. So very important. They will give you history somewhat like this. A child had a brain tumor in his younger days. A child had a brain tumor in his younger days. Infratentorial brain mass was there in 8 years, and now you are finding occult stool blood, refractory iron deficiency anemia, and you look for polyps will be seen there. Yes, that is how you will look at. Then Lynch syndrome. Lynch syndrome, colonic carcinoma, which is a HNPCC, by the way, hereditary non-polyposis colonic carcinoma, then endometrial carcinomas, ovarian carcinomas. This is HNPCC. Just to brush up, FAP will have a APC mutation. Lynch syndrome will have MSH, MLH mutations, right? Yes. So Lynch syndrome. So endometrial carcinoma. So how will they give you? Patient is again having an anemia, refractory anemia, presenting to you with polyp, and this in Lynch syndrome there will be a sessile polyps will be there. That will be your Lynch syndrome. Just a minute. Sorry. So there will be sessile polyps there. That is what you will end up seeing. Sessile serrated adenomas will be seen there, right, in Lynch syndrome. And HNPCC, history of colonic carcinoma, along with the other things that I have just mentioned here. Next, one more inherited could be a Cowden syndrome. Cowden syndrome, look at this, confusion starts with here now, because many overlapping features. Cowden syndrome is occurring due to what mutation? PTEN mutation. PTEN mutation. Cowden will have breast carcinoma. Then it will also have thyroid malignancies, endometrial malignancies. Same thing, endometrium is overlapping, and of course also will have a colonic carcinoma can be there, Cowden syndrome. Then apart from that, Peutz-Jeghers syndrome. Peutz-Jeghers syndrome will also have polyps. So this will be hematomatous polyps due to SKT11 mutation. We all know that, or also called as LKB1 mutation, SKT11 or LKB1 mutation. Yes, will have GI polyps and GI cancers. So GI cancers can be in stomach, intestine, anywhere. So anywhere there can be there, right? Stomach, colon, pancreatic cancers can also be there. Pancreatic cancers can be there. So look at this. Examiner can keep twisting. So look at the history. In the same patient, you need not have the multiple cancers. All of them are autosomal dominant in inheritance, by the way. So it can be, child is having this disease, mother had something else, mother's brother had something else. So such history will be given. So keep looking for those things. Now, next, just to tell you few things here, combining this, familial medulloblastomas. Where all you get familial medulloblastomas? We just studied one in a Turcot syndrome, correct? Familial medulloblastoma, you get one in Turcot syndrome, which will have a FAP with medulloblastoma. So how the question will come here? FAP with medulloblastoma, Turcot. One more is a Gorlin syndrome. Gorlin syndrome will have a BCC, basal cell carcinoma plus medulloblastoma. So examiner will ask you a question like this. Patient is having a medulloblastoma and, his father was having a BCC, basal cell carcinoma, and what is the next investigation you will be doing? Which genetic test you have to do? Many people confuse this genetic test. You need not mug them up. No, do not think that these are only one-liners. I just gave you an example just now. I give you a history of patient having, what do you call, medulloblastoma and parent having a basal cell carcinoma. Which genetic investigation you want to do in this? Answer will be PTCH mutation. That is your Gorlin syndrome. Next, apart from this, one more I want to discuss, familial skin cancers. These also can come as question. Familial skin cancers. There can be various skin cancers occurring in different conditions. Let us discuss. First one, xeroderma pigmentosa, which is an autosomal recessive disease, will have skin cancer, SCC most common, followed by BCC, followed by melanoma of skin. Apart from this, it will also have ocular melanomas. So ocular melanomas. Yes. Right. Next is Fanconi's anemia. Fanconi's anemia is an X-linked recessive disease, and this is associated with squamous cell carcinoma and AML, acute myeloid leukemias. Then Gorlin syndrome, we just discussed. Gorlin syndrome will have BCC plus medulloblastomas. Gorlin syndrome, PTCH mutation, right? PTCH mutation. So this is how I end up looking for keywords. Apart from this, one more keyword that you might get in neoplasia will be the paraneoplastic syndrome. We have discussed them enough in our regular class. The same table will hold true. Each paraneoplastic syndrome is a important keyword for different malignancies. Okay, so keep looking at paraneoplastic, and of course we'll discuss them in certain this one. One more I would like to give you is, yes, recurrent infection with increased incidence of malignancies. Commonly, there will be malignancies like leukemias and lymphomas. So very important. This is, now don't confuse, leukemia, lymphoma by themselves can cause a immunodeficiency disorder, secondary immunodeficiency, but they can also be associated with a primary immunodeficiency disorder, and they will give recurrent infection, malignancies history, and also they will give you some neurological manifestation like ataxic gait or abnormal gait. Examiner will not use this word ataxia straightforward because you will end up making a diagnosis. He will try to modify your ataxia like abnormal gait, or he might end up describing the ataxic gait itself, and that will be your ataxia telangiectasia. Ataxia telangiectasia is a combined immunodeficiency disorder. It will have dilated capillaries, telangiectatic patches, ataxia will be there, and also leukemia, lymphoma will be there. Now, the last thing from this neoplasia topic that I want to discuss, grading and staging in general in any tumor. When I expect grading and staging, I don't, of course, in individual tumors, you would have discussed this grading and staging in detail about them. But in general, I will give you, this will be giving you most of the hints, and 50% of the options will be ruled out based just on these hints anywhere. So whenever they ask you about the grade and stage, the keywords that I keep looking for grades, I keep looking for pleomorphism, Yeah, you can also find it in DVT, pleomorphism. Look for pleomorphism and look for high nucleocytoplasmic ratio and mitotic count, increase in mitosis. So any one of them or all of them are there, I start thinking of a high grade tumor, high grade tumor. If none of these are there, then I am thinking of a low grade tumor. Any one of them is there. So you know how I'll give a low grade tumor patient is having a tumor in the kidney and the nuclei are monomorphic. The nucleocytoplasmic ratio is 1:4, which is normal. By the way, mitosis are not found. I will then say it's a low grade tumor, right? Yes. Then on the contrary, for stage, very simple. For stage, you look for lymph node metastasis and also distant metastasis. Lymph node or adjacent organ involvement or distant metastasis. If any one of them is present, high stage, usually stage 2, 3 or 4, depends on different stages, but stage I can just tell you high, it will not be low. And if all of them are absent, no lymph node, no organ involvement, everything, nothing is there, then it is a low stage disease, stage 1. So how will I give you a question? Let me say a patient present with jaundice and there was on imaging, there was a tumor in the liver and biopsy from the liver shows, neoplastic cells which were uniform in size. The nucleus is uniformly located and the nucleocytoplasmic ratio is 1:4. No mitosis was found. The tumor is well encapsulated and the what do you call, lymph nodes are absent, lungs, everywhere else, no evidence of any metastasis. So I will start thinking of I'll start thinking either this is a benign tumor totally. Yes, if there is no invasion, it's a well encapsulated, no invasion, then I'll think of a benign tumor. If invasion was given, it's a malignant, but it's a low grade with a low stage because it has not metastasized anywhere. So this is how I'll be getting questions on general pathology. Now, one thing just to tell you about this thing, and you will start seeing this in exam, in all the exams that you already given so many clinical vignettes. Whenever you look at the question, it appears, everything is about patient here. Yes, everything is about patient doesn't mean only, patient related things are asked. Basically, there will be a lot of pathology questions which will have a clinical application, and basis of that will be pathology. So if you have understood pathology well, you will end up stretching your logic and making most of the diagnosis correct, because when we start our important systems. Now next I'll move on to the important systems here. The first one is cardiovascular. So in cardiovascular system, the vasculitis. So vasculitis is a very important. Usually vasculitis are the one which will present with generalized manifestation because there can be multiple vessels involved, and of course depends upon which vessel will be involved. We already know of them. Keywords I am looking for. What keywords will I look for in vasculitis here? First one, I look for granuloma, which is a microscopic keyword, by the way. On microscopy there is granuloma, and patient is also having a vasculitis or suspected vasculitis. So very important, granuloma is very important for vasculitis. Where are granulomas present? Intravascular granuloma, that means within the vessel itself. So this is called granulomatous vasculitis. So vessel is having granuloma, inflammation. Granuloma is a chronic inflammation, by the way, or extravascular granulomas. So if the granulomas are outside the vessel, not inside the vessel, that means granuloma is not causing vasculitis. There is a vasculitis happening and granuloma is a separate entity happening. Since granuloma is a type 4 hypersensitivity, it can happen just like that as well because of a type 4 hypersensitivity vasculitis sometimes. Now, if there is an intravascular granuloma, that means vessel, inside the vessel, if you find granuloma, yes, you start thinking of a GCA and a Takayasu. Yes, GCA and Takayasu. What is GCA? Giant cell arteritis, Takayasu, or it could even be a Wegener's granulomatosis. Wegener's granulomatosis. GCA, Takayasu, both of them are large vessel vasculitis. Wegener is a small vessel. So the clinical distinction is totally different here. Yes, large vessel, small vessel. Small vessel will present with petechiae, purpura, renal involvement, lung involvement. Large vessel GCA, Takayasu will present with, temporal or blindness or headache or, pulseless disease in the upper limb. So small vessel and Wegener usually with renal involvement. Renal involvement will be there. And there is a glomerulonephritis happening in kidney. That is Wegener's granulomatosis. Then The extravascular granulomas could be Churg-Strauss syndrome. So look at this, Churg-Strauss syndrome will have granulomas, but it will not be within the vessel, it will be outside the vessel. This is how examiner will give you a hint, or he will show you an image and there are no granulomas there, right? So this will be a small vessel vasculitis with renal involvement. There will be renal involvement here also, glomerulonephritis will be there, and there will be eosinophilia will be there. So this is the key word that you will be looking for, eosinophilia. Yes, eosinophilia, allergy or asthma. Yes, whatever I'm going to take, gold mine for examiner, land mine for you guys. So, you step this side, you end up, there's a trap. Everywhere there'll be a trap kept for you. So be, while negotiating, be very careful with the traps. So now look, patient is having a glomerulonephritis. I give you patient is having granulomas, involvement of lung is there, involvement of, kidney is there, small vessel vasculitis is there, and I give you an image in which there is a granuloma located or giant cell located inside the small vessel. Then I start suspecting not of Churg-Strauss, I start suspecting of your Wegener's, not of Churg-Strauss. Very important. Yes. And then other than that, asthma, allergy, if I'm giving you a history of that, then I'll think of a Churg-Strauss, right? So in Wegener's, in addition to kidney and intravascular granulomas, you can also have a respiratory granulomas. So these are separate. Extravascular also are present there. So extravascular granuloma doesn't rule out a Wegener's. Intravascular makes a diagnosis of Wegener's here, right? And of course, one more thing, how can hint will be given. Both of them are ANCA associated. Your Wegener's will have a C ANCA and Churg-Strauss will have a P ANCA. So very important keywords here, eosinophilia, allergy, asthma and intravascular granuloma. P ANCA and C ANCA will help us because both of them. So very important, your microscopic pan is not a DD for your, granulomatous vasculitis. So intravascular, extravascular granulomas, P ANCA, C ANCA, eosinophilia, etc. All these are. Large vessel vasculitis, less than 50, more than 50, more than 50 giant cell, less than 50 Takayasu. So this is how I will approach. Yes, Wegener's will be in lung also. So now don't confuse, lung involvement is also seen even in your Churg-Strauss, which will have asthma and allergic manifestation. Might not be exactly granulomas present there, but yes. So this is how we diagnose them. Next. Renal involvement in a patient with vasculitis. This is another gold mine for exam. Whenever there is kidney involvement in vasculitis, very, very important. Kidney involvement doesn't always mean glomerulonephritis because kidney can be involved, glomeruli can be involved, which is a small vessel vasculitis. And if renal artery is involved, a medium to large vessel vasculitis, it can be. So check for hematuria. Hematuria present or hematuria absent. If kidney is involved, if hematuria is absent, that means glomeruli are not involved, probably your larger vessel is involved. What is that? What is that? Medium vessel vasculitis, like a renal artery or its branches are involved. So example for this is a polyarteritis nodosa pan, right? It's a polyarteritis nodosa. So what will you look for here? History of hepatitis B infection will be there because it's an immune complex with HBsAg. And rarely Kawasaki also can involve kidney, right? Kawasaki can also involve kidney, rare. So just to know, histologically we cannot differentiate between them. Kawasaki is more in childhood, that is it. Otherwise you cannot distinguish based on histology. Just based on history we will end up differentiating. Kawasaki mostly causes coronary and mucocutaneous syndrome. We all know that, right? If hematuria is present, then it is suggestive of glomerulonephritis. That means I'm suspecting a small vessel vasculitis. So very important, if you are suspecting a vasculitis, there is a small vessel vasculitis, multiple DDs again. It could be an immune complex mediated or it could be a posse immune mediated. So two important. Yes, it could be an immune complex mediated. Immune complex mediated. Yes, it could be an immune complex mediated and a posse immune. Yes, it could be an immune complex mediated, posse immune. Right. So now I'm talking, if it is an immune complex mediated vasculitis, it could be multiple things like what? It could be HSP. One is HSP. or lupus. Both of them are immune complex, henox-Nolan purpura, lupus. In HSP, it is a IgA deposits will be seen. So there will be history of some IgA, elevated IgA in the blood will be given or deposits. Then also they will give you history of respiratory tract infection, and usually it occurs in children, by the way, HSP. So respiratory tract infection will be given. Other than that, petechiae, purpura, abdominal cramps, anywhere it can happen. Lupus, okay, children history will be there in HSP. Lupus will be middle age females, middle age reproductive age group females. They would have given a butterfly shape, malar, rash, etc. That will be given as a history there. Now, posse-immune could be with granulomas, without granulomas. So, posse-immune are with granulomas, without granulomas. Without granulomas are your microscopic polyangiitis, MPAN. So, this is P. ANCA associated. With granulomas could be, intravascular granulomas that will, and respiratory granulomas, Wegener's, extravascular granuloma, and eosinophilia, asthma, etc. That will be your Churg-Strauss, right? So, this is how I will approach any of your renal involvement in case of a vasculitis, whenever you get a renal involvement in case of vasculitis, right? Next, histological changes in myocardial infarction. So now look, what I have done is, although classically we try to teach in a different way, I'm going to give you how examiner going to ask question. Histological changes in MI I am discussing now. So in the histological changes in MI, so let me draw a graph here like this so that it becomes more easy for us to understand, and also where will clinical vignettes come. So usually clinical vignettes will be coming like what? They will give you patient died for some reason. At autopsy, the image of the heart is showing some area, and that suspicious area is taken and it shows following features. What is the likely diagnosis? So I'm writing 4 hours, 12 hours, 1 day, 3, 5, 7, 10, 14 days. So I'm writing like this. So 4 12 hours are 2 hours there. Rest all of them are days that I am going to show here, right? So this is my graph. What am I going to now do in this is, now look at this. I'm drawing a curve here. This is your new coagulative necrosis. Remember, coagulative necrosis up till 4 hours, you hardly find any coagulative necrosis. It starts by 4 hours, reaches a maximum somewhere by 3 days. Once it reaches maximum, it almost is a 0 by 7 days because your macrophage will be eating them, right? The dead cells. So this is what is your coagulative necrosis. Neutrophil will follow the coagulative necrosis. Slightly later, instead of 4 hours, they will start somewhere by 12 hours and reach a peak again by around 3 days and almost disappear by 7 days, neutrophils. Next is your, so very important point is between this 4 hour to 12 hour, this window, what will you see? Between this window, 4 hour to 12 hour, you will only find necrosis. You will not find neutrophils. Remember this. They will give you this coagulative necrosis seen, no neutrophils are seen, then it will be somewhere between 4 to 12 hours, maximum 4 to 24 hours, but never more than 1 day, right? So next is the macrophages. When do macrophages start? Macrophages will start somewhere on 3 days and reach a maximum somewhere between 7 to 10 days and start depleting after that. So maximum macrophages around 7 to 10 days, and after that they deplete and become 0 by 14 days. So very important, from 3 days to 7 days, look at this graph, what all will you see in the infarct? From 3 days to 7 days, you will see macrophages, depends on more or less number of macrophages. You'll also see depleting neutrophils, depleting coagulative necrosis as well. So you will see everything here. You will see necrosis, you will see neutrophils, and also you will see macrophages. Everything you are seeing here. Now, what do you see between this? 12 hours to 3 days. So look at this. What are you seeing here? Between 12 hours to 3 days, you are seeing both neutrophils as well as necrosis. Neutrophils as well as necrosis. Coagulative necrosis and neutrophils. Both of them are seen here. Then after this is your granulation tissue. So look at granulation tissue. Where does granulation tissue start? Somewhere around 7 days and reaches a maximum by 14 days. After that, it depletes. Granulation tissue. So this is your granulation tissue. Now look, very important. Again, what question can come? Maximum granulation tissue around 14 days. Now what will you find? After that, collagen. Collagen starts after 10 days and it reaches maximum after 2 weeks, collagen. And it will not reduce, it will keep flat. Right? So important, what will you find between 7 to 10 days? In between 7 to 10 days, you're finding macrophages, roughly maximum macrophages. There will also be early granulation tissue, no collagen, basically. That means macrophages, maximum early granulation tissue will be finding. So occasional granulation tissue. Then between 10 to 14 days, what do you find? Between 10 to 14 days, you'll be finding early what do you call, between 10 to 14 days, early collagen, very few collagen bundles, but maximum amount of granulation tissue. So, examiner will give you a permutation combination of these things. The bottom line here, this is what is expected. So biopsy from the infarct shows neutrophils only, neutrophils and coagulative necrosis. Start suspecting between 12 hours to 3 days, or 1 to 3 days. You can say only necrosis or neutrophil necrosis and macrophage. Everything is seen. Then 3 to 7 days. Macrophages and granulation tissue 7 to 10 days, and macrophage and collagen, macrophage, granulation tissue and collagen will be around 10 to 14 days. After 14 days, you will find only the granulation tissue and also the collagen. After 3 weeks, no granulation tissue, only collagen will be seen. This is how examiner can end up giving you question. So this was important keywords for cardiovascular system. Next, I will go on to the lung carcinoma. In lung carcinoma is the most important, and keywords are here. So I am discussing multiple things: small cell carcinoma, squamous cell carcinoma, and adenocarcinoma. Three important ones. So what all things we look for? Keywords: SIADH, which will manifest with hyponatremia, which will have CNS manifestation, confusion, delirium, coma, etc. So will be seen in mostly small cell carcinoma. Cushing's also mostly small cell carcinoma. Hypocalcemia can occur because of excessive calcitonin production, also seen in small cell. Don't confuse this with hypercalcemia. Hypercalcemia will be because of a parathormone related peptide seen in squamous cell carcinoma. Very, very important is this. Apart from this, keywords will be the markers for the lung carcinoma. Markers for lung carcinoma. What are the different markers that we use for lung carcinoma? TTF1. TTF1 is positive in the first one is small cell, second one is squamous, third one is adeno, by the way, right? Yes, TTF1 is positive in small cell, negative in squamous, positive even in adeno. So TTF all except squamous. Napsin. Napsin is a protease of type 2 pneumocyte. That is why it is present only in alveolar pneumocyte, adenocarcinoma. Napsin. P40 and P63. These are markers of squamous differentiation. So napsin is a marker for type 2 pneumocyte. I told you it's a protease of type 2 pneumocyte. So P50 and P40 and P63 are squamous cell markers, positive in squamous cell carcinoma. Squamous cell carcinoma. Next is chromogranin. Chromogranin and synaptophysin. Both of them, chromogranin, synaptophysin, are positive in your small cell carcinoma, negative in the other two. Small cell and negative in the other two. Next, one more is your cytokeratin. Cytokeratin CK7 and 20 we do. CK7 20 mostly is done for adenocarcinomas, but anyways I have to just write CK7 and 20. 20 will always be negative. 7 can be positive sometimes in small cell and squamous cell, both of them. And 7 will always be positive in your adenocarcinoma. So CK7 will be positive in adenocarcinoma of lung, negative 20 will be CK20 negative. Other than that, what else history would have been given to you? Look for, these could also be your clinical hints that will be given. One is your squamous keratin pearl formation, that is a squamous cell carcinoma. This is your squamous cell carcinoma. Look at this. These are your dark blue shaped nuclei and a very closely packed nuclei. This will be seen in small cell carcinoma, and gland formation will be seen in adenocarcinoma. Gland formation, adenocarcinoma. For mesothelioma, they would give you a hint of asbestos, which is one of the cancer causing agent for mesothelioma. Not as a marker, it will be a biphasic tumor. So both gland formation and also spindle cells will be seen in mesothelioma. Okay. Yes. So this is, lung. Next, we'll move on to the GIT. Important in GIT, keywords. I am talking about the gastric carcinoma. So in gastric carcinoma, look at polypoidal mass or ulcer with loss of rugae. So polypoidal mass is an intestinal type of gastric carcinoma. Ulcer with loss of rugae is a diffuse type of gastric carcinoma. Diffuse type of gastric carcinoma. So polypoidal mass will have APC beta catenin mutation, where yes, and even Bax mutations seen. Yes, Bax mutations are also seen. Whereas your ulcer with loss of Ruge, CDH1 mutations will be seen. CDH1 mutations will be seen, and this will lead to loss of E-cadherin there. So loss of E-cadherin will lead to signet ring cells. We know that, right? So in polypoidal, you will see glands plus minus mucin. There will be no glands seen here in case of a flat type or a diffuse type. You will see mucin, yes, but you will see signet ring cell carcinoma, signet ring cells. So signet ring cells, and this is the one which can be familial or even sporadic CDH1 mutation. It could be a familial CDH1 or a sporadic CDH1 mutation. So this is how your signet ring cells will appear. Signet ring cells will have multiple vacuoles inside the cell. Look at this. This is all the mucin present, and the nucleus is pushed towards the periphery. This is how signet ring cell will appear. Other gastric tumor without mucosal involvement, that could be there. So no mucosal involvement. Gastric tumor without mucosal involvement. Then what do you suspect? Gastric tumor without mucosal involvement could be two of them. Either it could be a submucosal or tumor is in the wall, in the muscle layer also. So DDs could be your lymphomas of stomach or a GIST, gastrointestinal stromal tumor. So very important hint that they will be giving you. Either there will be a spindle cell tumor that will be given, then suspicious of GIST for sure. Otherwise, there will be a lymph node involvement along with the stomach. Perigastric node is involved. GIST will be ruled out almost because it will not show a lymphatic spread. Lymph node involvement is present, then you start suspecting a lymphoma. Other than that, for lymphoma, other key history will be given H. pylori. H. pylori infection definitely start suspecting of lymphoma. Which lymphoma we suspect here is a H. pylori will be suspecting a maltoma there, right? That is what we are going to suspect, maltoma. So, and also no B symptoms because this is a low grade tumor. If it is B symptoms are present, then we suspect of a DLBCL, diffuse large B cell lymphoma. Markers for maltoma, CD5, 10, 23 negative, 43 positive, BCL2 can be positive. Marker for GIST, CD117, DOG1, and treatment for GIST will be imatinib because c-KIT tyrosine kinase inhibitor, which will act on the c-KIT, by the way, tyrosine kinase. And treatment for maltoma will be antibiotics, basically anti-H. pylori therapy. And for B symptoms, it is a DLBCL, then it will be CHOP. That will be the treatment that will be given. CHOP will be the treatment. Now look at this, the histological hint, how will you get? Very important, maltoma will be submucosal. This is your mucosa. I hope all of you are able to see the mucosa here. And this is your lymphoid follicle formation. This is how the maltoma will look like. And this is your actually a Warthin starry stain in the corner. H. pylori is positive. So, this is how maltoma hint will be given. The next image is your spindle cell, which will also have epithelioid cells, by the way. Any spindle cell tumor in stomach, start suspecting of a GIST here, right? GIST, gastrointestinal stromal tumor. Next, one more, malabsorption syndrome keywords. So pathological keywords, I am looking for malabsorption associated with multiple associations like type 1 diabetes mellitus, associated with Sjogren syndrome, autoimmune diseases like Sjogren syndrome, or associated with IgA nephropathy, or even recurrent infections, recurrent respiratory tract and GI infection. If you remember, and allergic manifestation, which was IgA deficiency. IgA deficiency is associated with celiac. All these are, and of course, gluten sensitivity also. Gluten sensitivity or gluten allergy, or they would have given you a T cell lymphoma, enteropathy associated T cell lymphoma, which has arisen there. So they will give you a history of malabsorption. There was a biopsy done and there will T cell proliferation, made a diagnosis of a T cell lymphoma, start suspecting of a celiac disease. Maltoma, anti-H. pylori therapy, anti-H. pylori, that is antibiotics basically. So this is where you suspect celiac. Celiac disease will be the suspicion. All these are hints for celiac. Of course, villus atrophy, crypt hyperplasia, these are your findings. Increase in intraepithelial lymphocyte. These will be your, yes, findings in celiac, right? Next, on the other side, the malabsorption syndrome in the GIT associated with something else, associated with other diseases like anemia I'm talking. So malabsorption associated with anemia, a lot of things can be associated with anemia, or even RBC changes. So if it is suggestive of iron deficiency anemia, remember iron is absorbed in the upper GIT. So if iron deficiency anemia is there, problem with the upper GI problem. So your gluten sensitivity is maximum in the upper GI because maximum exposure to gluten is happening in the upper GIT, or associated with vitamin A, D, E, K deficiency also, which are fat soluble. So there is a fat malabsorption. We will think of, yes, fat malabsorption. Suspect if peripheral blood shows acanthocytes, for sure A beta lipoproteinemia. Both of them can manifest with anemias, by the way, right? Acanthocytes, A beta lipoproteinemia can be there. If it is suggestive of just IDA, microcytic hypochromic anemia, then upper GI problem, suspect celiac again. So suspect a celiac disease. Suspect of celiac disease. Now, do not confuse upper GI when I say if stomach is involved, then there can be a malabsorption of vitamin B12 happening. Not in celiac disease. We suspect if it was an autoimmune gastritis there, right? So not in celiac. So for acanthocyte, what will you find? Of course, if there are acanthocytes, intraepithelial lipid vacuoles, that will be diagnostic of your A beta lipoproteinemia. Just to show you those images here, look at this image. This is the image, sorry. So just to show you two images here, this is the image of, the first one is the image of celiac disease. I can see this is all crypt. Crypt is very hypoplastic, and this is your villus. Villus is very, very flat here. And the second image on the left hand side are your lipid vacuoles seen inside the epithelial cells, A beta lipoproteinemia due to MTP deficiency, where there is intraepithelial transport of lipid is abnormal, and these are your acanthocytes. So these are keywords, mix and match, anemia will be given to you. Any malabsorption syndrome can manifest with anemia with what? Peripheral blood smear finding, very important. And this is one more malabsorption syndrome. Just look at this. Epithelium is normal, but subepithelium is having pass positive macrophages. Worm infestation, yes, worm infestation will present with bleeding manifestation also. Yes, worm infestation also can be a cause of, but not, they will not present like diarrheal manifestations that we are talking about. Okay, yes. So this is your Whipple's disease, subepithelial or submucosal pass positive cells. These are macrophages which will be having the bacteria inside them. Next is the polyp, intestinal polyp keywords. So I'll not show you the images. We have discussed the images. Yes, the keywords I will discuss in the intestinal polyps. So very important keyword in the intestinal polyp will be your age. So the most important for keyword for intestinal polyp is the age at which the polyp was diagnosed. If it is a child or an adult, very, very important. If it is a child, then it could be a juvenile polyp, or it could be a Peutz-Jeghers polyp. Both of them occur in children. And for Peutz-Jeghers polyp, you can look for other manifestations like hyperpigmentation, all those manifestation. Juvenile polyp will be cystically dilated glands will be seen, whereas in a Peutz-Jeghers polyp, associated manifestations could be, the hyperpigmentation or mucocutaneous pigmentation will be there, and there will be smooth muscles in the mucosa. So, or in the submucosal region, there will be smooth muscle. This is a hematomatous polyp, by the way, Peutz-Jeghers. In adult, if you are thinking of, then it could be a tubular adenoma or it could be a villus adenoma. Two things. Adult will be a tubular or a villus adenoma. The tubular adenoma will show branching gland-like pattern. Whipple's disease, they will give you mucosa is unaffected, submucosally you are seeing macrophages. That is what is diagnostic of Whipple's. Branching glands will, whereas in villus there will be finger-like projections, finger-like tall structures, projections will be seen. Apart from this, tubular adenoma will also be pedunculated. Villus will be sessile. I will not use that. Yes, CNS involvement will also be there in Whipple's, correct? Yes. So pedunculated and sessile. So let me just brush up your the polyp. Look at this. What am I seeing in this? This is a 5-year child bleeding per rectum. Straight away, I will make it as a juvenile polyp. Cystically dilated glands that are seen. This is your juvenile polyp, or we call it commonly occurs in rectum, juvenile rectal polyp. This is a 10-year child having a hyperpigmentation in the oral cavity, and this is what is a polyp. Or I can give similar histories there in the parent also, because it's an autosomal dominant condition. So these are your branching glands, and in between you are seeing these are the smooth muscle which will be arborizing, Christmas tree like pattern. Christmas tree like pattern. That is what is your this is your Peutz-Jeghers polyp. This is your, now look at this, these are your just a polyp which is having a stalk pedunculated here, and there are branching glands. Some of them are cystically dilated as well. This is your villus adenoma. This is your tubular adenoma with a stalk and branching glands are seen. Then on the other hand, look at this. This is your tall villi. So these are finger-like projections. Look at this very tall finger-like projections. What do we call this? This will be a villus adenoma. Villus adenoma. This will be a villus adenoma, right? Yes. So this was about the disorders of the GIT. Now next is important I want to discuss is the renal pathology, a very, very important one. So let me just go through this renal pathology. Keywords for renal pathology. So in keywords, very, very important keywords in renal pathology, look for what is the manifestation. Clinical keywords I am looking for. Hematuria, hypertension. Hematuria, hypertension, even RBC cast in the urine. Or there is a albuminuria, and also lipiduria. Albuminuria, lipiduria. So of course, one is a nephritic. Hematuria will be nephritic. RBC cast definitely nephritic, and albuminuria and lipiduria will be nephrotic. So yes, villus is poor. Villus is poor. The worst will be the serrated adenomas, which are having villus-like feature and serrated also. Okay. Yes, there's one more tubulovillus also, which will have both features of tubular and villus adenoma. Now look, nephritic, nephrotic. So both of them, nephritic, nephrotic. Villus is the most malignant out of these three. Now nephritic, nephrotic. So if nephritic, check for features suggestive of acute renal failure in the patient. So acute renal failure, I look at anuria, all those acute renal failure patient, yes or no. If acute renal failure symptoms are there, then we are suspecting clinically an RPGN, or pathologically I can call it as a crescentic glomerulonephritis. Pathologically, crescentic glomerulonephritis. So now if I am suspecting a RPGN or crescentic glomerulonephritis, then what do I look for? Yes, I will look for immunofluorescence. Immunofluorescence shows linear deposits, or immunofluorescence shows granular deposits or no deposits. See, light microscopy will always show crescents. Yes, light microscopy will always show crescents. Yes. So that is how I will differentiate. Now, linear deposits, only diagnosis I can think of is a Goodpasture syndrome. So other clinical words they would have given you a hint will be hemoptysis. They would have given you hemoptysis, right? Next is granular deposits could be lupus or could be HSP. Already I told you history will be child with respiratory tract infection, HSP, lupus, middle age female, etc. Then even PSG and IgA nephropathy also can cause rarely the crescentic glomerulonephritis. Then no deposits will be your Possimmune, Wegener's, microscopic pan, and Churg-Strauss. I already have discussed how do I differentiate between them. So I'll not get into that, right? Yes. So this is your crescentic glomerulonephritis, which will have a nephritic feature plus rapidly progressing to acute renal failure. No history of acute renal failure. Then we are thinking of a acute nephritic syndrome without any complication of RPGN. So check for history of a respiratory tract infection. Then yes, there is a respiratory tract infection. No, there is no respiratory tract infection. Respiratory tract infection, if it is there, check what is the rough age of respiratory tract, more than 1 week or less than 1 week. So look for more than 1 week or less than 1 week. If it is more than 1 week, then we suspect a PSGN. Less than 1 week, IgA nephropathy. Of course, other than that, in PSGN, they can give antibody titer, which might be elevated. All those things can be given, right? Yes. IgA nephropathy, synpharyngeal we call it. Yes. PSGN, hypercellular glomeruli will be seen. Yes, there will be hypercellular glomeruli. In IgA, there is the mesangial proliferation, expansion. It's also called as a mesangial proliferative glomerulonephritis. So this can come on the other side as well. So no respiratory tract infection. On the other side, there is a no respiratory tract infection. Then what do I look for? If there is no history of respiratory tract, look for history of autoimmune disease like SLE, rheumatoid, etc. Or look for drugs, or look for idiopathic. Many things you will not know anything there. So look for drugs, idiopathic, some infections like syphilis, malaria, hepatitis B, hepatitis C, autoimmunity like SLE, etc. So this will be if it is very suggestive of MPGN. MPGN, remember, can present with nephritic, even with nephrotic. Even MGN also can rarely present with nephritic, mostly nephrotic, but rarely present with nephritic. So if it is MPGN, what do I do for? Look for histopathology. How does it help me? Histopathology will show tram track appearance. I'll show the image subsequently. Don't worry about it. Tram track appearance. Now confirm with IF. Immunofluorescence. Immunofluorescence, if it is an immune mediated, then there will be immune deposits including immunoglobulin, complement C3, C1q, C4. All complements and immunoglobulins are deposited. Then it is a type 1 MPGN. Only C3 is deposited, which is a C3 nephritic factor induced. That is a type 2 MPGN. Remember, in a type 2 MPGN, there is no immune complex. It's not an immune complex mediated disease. Basically, in a type 2 MPGN, there is an autoantibody to the C3 convertase, and with this C3 convertase remains active because of this antibody. So because it remains active, then there will be what? Constant activation of alternate pathway of complement, dense deposit disease, or type 2 MPGN. So I'll show you the images as well. Don't worry about it subsequently. Yes, correct. Berger disease is same as IgA nephropathy. So now nephrotic syndrome. Let me go at the nephrotic syndromes. So in a nephrotic syndrome, child or adult child, if there is a child history of RTI, respiratory tract infection, responding to steroids, then definitely I'm thinking of a minimal change. So minimal change disease, of course, no change in the glomeruli. We all know that there will be vacuoles in the tubular cells and effacement of food process. On the other side, if it is an adult, then we'll not make a diagnosis of minimal change. Then we'll look at histology. Histology, if it is showing sclerosis or it is showing basement membrane thickening. If it is showing sclerosis, suspect FSGS. If it is showing basement membrane thickening, then we'll discuss something else. That will be MGN. Now, in a child not responding to steroids. So very important, child sometimes do not respond to steroid. Could be because of inherited like nephrin mutation or all those mutations, and that will lead to FSGS in the child. So child could also have a FSGS, important, remember this, but not responding to steroid. Very important. Steroid resistant they can be. Of course, you have to make a diagnosis based on biopsy there, right? Yes. So patient can have, because of sclerosis, there can be hypertension happening. So very important, they will start giving you normally in minimal change, there will be no hypertension happening because there is no retention. But however, when sclerosis happens, then there can be hypertension happening. So FSGS can have hypertension. So other than that, even hypertension can cause FSGS also, by the way. And then sickle cell disease can cause this, etiology, reflux, HIV, etc. can cause this. Look for basement membrane thickening. If basement membrane thickening is seen, then spikes in the basement membrane, if they are seen, definitely we are thinking of a MGN. For MGN, usually we get a history of malignancies, etc. That will be given to you there, right? And elderly patient, not young. FSGS occurs in adults, but in young adults, not elderly, whereas MGN occurs in elderly. MGN occurs in elderly. So just to give you last one in the kidney, electron microscopic finding, multiple electron microscopic finding in the kidney, subepithelial humps. Where do you see subepithelial humps? In PSGN, and subepithelial deposits will be seen in MGN, membranous glomerulonephritis. Subendothelial, where do you get subendothelial? You will get it in lupus. You will get it in PSGN. Remember, PSGN will have subendothelial deposit. Initially, they migrate to the subepithelial later. And also subendothelial in MPGN type 1, subendothelial. Then mesangial deposits, where do you get mesangial deposits? Mesangial deposits in IgA nephropathy and also in FSGS, mesangial deposits. IgA nephropathy, FSGS. Then effacement of food processes, where do you get it? Minimal change disease, FSGS, MGN. So it is a non-specific for minimal change, nothing there. Next is basement membrane. So we'll talk about basket view of appearance on EM. Basket view appearance will be seen in Alport syndrome. Then there will be disruption of basement membrane. So basement membrane gets disrupted when crescentic glomerulonephritis, disruption of basement membrane. Then also ribbon-like dense deposits, also called dense deposit disease, type 2 MPGN, type 2 MPGN, dense deposit disease, type 2 MPGN. So, this is whole of your kidney. So whole of your kidney, quickly revised for you guys. So the images, I'm sure you would have looked at the images. Let me just try to show this. Look at this. This is a hypercellular glomerulus. Patient is having a respiratory tract infection 2 weeks back. Presents with hematuria, RBC cast, hypertension. Your diagnosis is your PSGN here, hypercellular glomerulus. So there are deposits, subepithelial humps are seen and subendothelial deposits are seen in PSGN. This is your lumpy bumpy deposit. We call this as a lumpy bumpy deposit, granular pattern which you see in PSGN. So this is your crescentic glomerulonephritis. What you are seeing here are the crescents. This is your crescent shape structure. One more crescent is here. These are your two crescents that you are seeing, crescentic glomerulonephritis. So in crescentic, I told you immunofluorescence is very important. This is your linear pattern, line-like ribbon. Many people keep asking me again and again, confusing. This is line, continuous line, linear pattern, Goodpasture syndrome. Look at this. This is also a line, but however, it is not a continuous line. It is having like this dotted line. So it is called as a granular pattern. This is your granular pattern. Where do you see granular pattern? In case of a immune complex mediated like lupus or HSP, granular pattern, lupus or HSP. How do I differentiate linear and granular? Dot like is your granular pattern, right? Then next is this is your mesangial pattern. This is expansion of mesangium, mesangial expansion, IgA nephropathy. Yes, IgA nephropathy, mesangial expansion, IgA nephropathy. So these are your IgA deposits. Where do you see such IgA deposits? In IgA nephropathy again. IgA deposits in mesangium. So this is your mesangial deposits seen in IgA nephropathy. Now look at this. This is your tram track appearance. How do I identify a tram track appearance? They will be giving you a silver stain like this. This is a silver stain. Basement membrane will appear black. And look at the capillary loops. Normally you should have only one basement membrane. You are having double basement membrane like this. So this is what is a tram track appearance. So double basement membrane will be seen, tram track appearance. So you can see here double basement membrane. You can see here double basement membrane. So everywhere, instead of one line, there are two lines seen, tram track appearance. Yes. So tram track seen in MPGN, both type 1 as well as type 2. This is your disruption of the basement membrane. I can see this is your basement membrane here. And in this part, there is a disruption. Disruption of basement membrane again seen in crescentic glomerulonephritis. Any of your crescentic glomerulonephritis. Both in type 1 and type 2 MPGN, you can see a tram track appearance. Oh, sorry. No. Yeah. So this is actually a crescentic one. Now look at this. This is your, yes, what are you seeing here? This is your spikes. So this is your capillary. In the capillary, you are seeing such spikes that are seen. This is your spikes, MGN. Membranous glomerulonephritis. I told you history. What history will you get? Probably you'll get a history of a malignancy here, MGN. And this is your deposit. This is your, okay, this is on the epithelial side. How do I identify epithelial side? Look for such a space, empty space. So look for this, a large empty space like this. This will be your endothelial side always. Otherwise, start looking for the fenestrated endothelium. So this is your endothelial or blood vessel, by the way, and these are the deposits on the epithelial side, subepithelial deposits. These are your subepithelial deposits. So subepithelial deposits you can see in MGN. So again, look at this. This is another electron microscopy. This is your this is on the capillary. CL is written, capillary loop. This is your basement membrane. And on the other side, there is effacement of foot processes. Effacement of food processes. Normally you should have had food processes here like this. So they are already lost. There is loss of food processes. Yes, loss of food processes. Yes, this is what is your minimal change. Not only in minimal change, I told you just now, loss of food processes can be seen in any of your nephrotic syndromes. Now, this is your FSGS. How do I identify this? So this is a very low power image, and in this glomerulus, there is a sclerosis seen. At your level, only identify sclerosis. This makes your diagnosis of FSGS. You can confuse this with a IgA nephropathy, by the way, but history will help you. IgA nephropathy will also have very similar sclerosis that might be seen, but however, in IgA nephropathy, more of nephritic or more of hematuria. In this is a FSGS, which will be more of your nephrotic syndrome, right? This is your collapsing. So for collapsing, the keyword HIV/AIDS. They will be giving you the keyword HIV/AIDS causing collapsing glomerulonephritis. Collapsing. This will happen because of proliferation of the epithelial cells. So when epithelial cells start proliferating, look at this. The black things are your glomeruli, the basement membrane here, and at many places there is collapse of the glomerulus. So these are the collapse because of proliferation. The glomeruli have got collapsed. No glomeruli. I cannot see the vessels at all here. Yes. Sclerosis also in IgA nephropathy. Yes, you can see only if it is a recurrent one, because IgA nephropathy keeps recurring. You can see sclerosis in IgA nephropathy if it is a recurrent one. Now, so I am showing three diseases here. Look at these three diseases, important ones. One, a normal basement membrane, the glomerular basement membrane, a thin one, and more important is the basket wave appearance. How do you see basket wave appearance? Your basement membrane appears like this, alternatively thick and thin. One is this basket wave appearance in your Alport syndrome, alternate thick and thin basement membrane. And not only that, so this will be your basement membrane, the yellow part that I am showing. And not only that, inside the basement membrane, this basement membrane which is alternatively thick and thin, which is called basket wave, and also you will see splitting of lamina densa. So the lamina densa, the purple one is your dark appearing lamina densa. Instead of one, there will be double lamina densa. Splitting of lamina densa will be seen. That will be seen in your Alport. Renal tumors, keywords for renal tumors. What do I look for? Yes, keywords for renal tumors. Keywords I look for brain involvement. This is a very important keyword for renal tumors with brain lesions or brain tumor. Now you're not expecting, usually lung carcinoma, you're expecting brain, but yes, here don't confuse, no metastasis to the brain. That is what is very important. They will give you this option always. Is there a match to the brain? So first query, is it associated with the tuberous sclerosis? That will be also involving brain. There will be lesions in the brain and also can be associated with a von Hippel-Lindau syndrome, which also will have tumors in the brain. So very important, if it is a tuberous sclerosis, that is history suggestive of a benign tumor or asymptomatic renal tumor, suspect of angiomyolipoma, which is associated with tuberous sclerosis. So patient will be having CNS manifestation, multiple tubers in the brain, so seizures, etc. will be the manifestation, and angiomyolipoma will be there in the kidney, asymptomatic mass, incidentally detected mass in the kidney. On the contrary, if the tumor is suggestive, in the kidney is a malignant tumor, like, okay, hematuria, etc. Symptomatic tumor is there, then we suspected malignancy like hematuria, yes, or even polycythemia as a paraneoplastic syndrome. So if you are suspecting a malignancy, then check in the brain. They would be giving you a history of cerebellar dysfunction that might be there, and there will be cerebellar lesion that will be seen. And this cerebellar region, they will ask you, is it metastatic renal cell carcinoma? Answer is no, it is not metastatic renal cell carcinoma. It will be a hemangioblastoma. It will be a hemangioblastoma where you commonly see in case of a VHL, right? Von Hippel-Lindau syndrome. So not only cerebellar tumor, even there can be a retinal angioma happening. So cerebellar hemangioblastoma or a retinal angioma that can be seen. That will be a VHL syndrome. Yes, and which is the RCC, clear cell RCC will be there. So very, very important, angiomyolipoma will have histology of blood vessels, whereas, clear cell RCC will be having clear cells that will be there. Yes. Okay, so classical renal malignancy, brain tumor, they will give, do not expect mets because RCC is metastasized most commonly to lung, second most commonly to bone, not commonly to brain. They can although, but not very commonly to brain. So if they are giving you suspicion something there, start suspecting a VHL. VHL mutation, which can have a tumor, cerebellar hemangiomas or retinal angiomas can also be there. And your tuberous sclerosis will not have a tumor in the brain, but yes, there'll be tubers that will be seen there, right? Yes, cortical tubers that can be seen there. So these were about. Now next is I want to discuss few keywords for hematolymphoid. Although I have discussed this in detail in one of the DVTs, what I'll do is I'll not repeat those things which I have taken in DVT. So in hematolymphoid, let me just make hematolymphoid neoplasms keywords. What are the keywords I'm looking for hematolymphoid neoplasm? Involvement of lymph node or other extranodal organ, like example spleen, plus minus spleen involvement, plus minus other organ involvement, or one more, only spleen and liver involvement, or bone lesions are present. So there could be hematolymphoid, could be spleen involvement, bone lesion, or only lymph node. If lymph node is involved, then I'll suspect lymphoma. If it is spleen involvement, if it is spleen involvement, and liver involvement, I suspect a myeloid neoplasms. And if it is bone marrow, spleen will not be involved in myeloid neoplasm, but there can be extramedullary hematopoiesis happening. And bone lesions, I suspect a plasma cell or a LCH. Plasma cell or LCH. The worst type will be, if at all given, the collecting duct carcinoma will be the worst one, yes, or carcinoma of duct of Bellini, that will be the worst type. Otherwise, clear cell is poor. Apart from that, clear cell is poor. Next. So now next is lymphoma. Keywords for lymphoma: localized lymphadenopathy or generalized lymphadenopathy. Localized lymphadenopathy, Hodgkin; generalized lymphadenopathy, non-Hodgkin. In non-Hodgkin, keywords I look for: B symptoms present, fever, weight loss, night sweats present or absent. So B symptoms are present, then I suspect it is a high grade. B symptoms are present, I suspect it's a high grade. Ki67 will be high. And if it is low Ki67 and no B symptoms, low grade. So when I'm suspecting low grade, the important low grade NHLs and the important high grade NHLs. What keywords? Clinical. I'm still talking clinical here, not talking markers. High grade, B symptoms present, high grade neoplasms, commonly Burkitt lymphoma, one very important high grade. Keyword: look for a African child, clinical history, African child, and a jaw mass, very important. So this can be the history. Otherwise, ALL also can be there, usually seen in children. No other clinical history will be given. Low grade, we are suspecting a B cell lymphoma, low grade non-Hodgkin lymphoma, commonly maltomas. Maltomas, what history we look for? H. pylori, right? H. pylori history will be there for maltoma, which is a low grade lymphoma. Then dyspepsia, etc. will be given. Then lymphoplasmacytic lymphoma. Yes, lymphoplasmacytic lymphoma. So if there is a lymphoplasmacytic lymphoma, this will lead to Waldenstrom's macroglobulinemia. Remember, so hyperviscosity syndrome, excess of IgM production will be there, thrombotic manifestation. So they will give you thrombotic manifestation, hyperviscosity syndrome, skeletal survey is normal, no lytic lesion in the bone. Because it is not a disease of multiple myeloma, then you are suspecting a lymphoplasmacytic lymphoma. Very important. What is the next investigation? Look for involvement of lymph nodes. If bone is negative, hyperviscosity syndrome is there, look for lymph node involvement, because it is not a multiple myeloma and now it is most likely a lymphoplasmacytic lymphoma. Yes. Then yes, CLL, SLL. Yes, of course. CLL, SLL. What history they can give you? One is history suggestive of AIHA, because CLL, SLL commonly is associated with warm type of AIHA, which will be Coombs positive or spherocytes present, etc. Something they will be giving you a history. Okay, so patient is being investigated for autoimmune hemolytic anemia. Now you find a lymph node enlarged, and now you start suspecting one CLL, SLL, because autoimmunity is there in CLL, SLL, right? Yes. So images will move on because we have already studied so many images. Just to show this image, okay. So this is your starry sky pattern and a clinical examination of a Burkitt lymphoma. So you have a Burkitt lymphoma, starry sky pattern here. Next is the hematolymphoid neoplasm with bone lesion, lytic lesion on the bone. In radiology, yesterday you would have studied this partly, by the way. Yes, very important. Bone lytic lesions are seen. One, it could be a metastatic. Many metastases can show this, but otherwise hematolymphoid neoplasm. Is it in a child or is it in an adult? Usually more than 50 year, usually, but child or an adult, very important. Child, if you are suspecting adult, look for associated CRF or increase in immunoglobulin, that is M protein will be increased, or hyperviscosity syndrome, etc., or proteinuria, especially your Benz-Jones proteinuria. Now we are suspecting a multiple myeloma. If it is in adult, we are suspecting a multiple myeloma. Lytic lesion in the child we are suspecting a Langerhans cell histiocytosis. The other history, you look for proptosis. There could be exophthalmos or proptosis happening. Then there could also be skin lesions or multi-organ involvement, generalized disease or lesions, multi-organ, which might be skin, muscle, lymph node, anywhere. It can be involving multiple. So it will not be a multiple myeloma. Remember, all the word multiple myeloma is multiple, but it will be multiple lesions inside the bone only. Here it is multi-systemic disease. It could be your Langerhans cell histiocytosis. Then look for diabetes insipidus, because multiple myeloma, Langerhans cell histiocytosis can involve the skull, base of the skull, compress your posterior pituitary, leading to diabetes insipidus. These history will be given, inability to concentrate urine, all those things. Langerhans cell histiocytosis, LCH, Langerhans cell histiocytosis. Of course, other than that, they might give you the blood examination or bone marrow examination. So bone marrow examination, if it is a plasma cell neoplasm, of course lytic lesions will be there. Plasma cell will have Mott cells like this and a blue cytoplasm. Very important, cytoplasm will be blue in case of multiple myeloma. This is your Mott cell, which is having immunoglobulin like inclusion. If it was a LCH, you will not see such blue cells. You will more see of eosinophilic cells. In fact, there will be a lot of eosinophilia only. There will be a lot of eosinophils deposited here, and you will see such electron microscopy might show Burbeck granules, tennis racket shaped inclusions, which are called Burbeck granules. That is what you will be seeing, right? Yes. So these are the keywords. Keywords for myeloid neoplasms now. Keywords for myeloid neoplasms. Yes, let me start with, okay, clinical words. Again, sudden onset and high grade fever, etc., or gradual onset. Look for sudden onset or gradual onset. Sudden onset will be, DDs will be AML mostly, but can also be MDS, sudden onset. Gradual onset, for sure, it will be MPN, even MDS can be there. So, first let me discuss sudden onset. Check for blasts. Sudden onset, MDS, AML, both of them will have blasts more than 20%, then or less than 20%. Blasts are more than 20%, definitely start making a diagnosis. If blasts are more than 20%, then what is your diagnosis? AML. Less than 20%, what is your diagnosis? Less than 20%, look for cytogenetics. Very important, do not rule out AML. Look for cytogenetics. Cytogenetics will have a translocation. If there is a translocation 821 or translocation 15, 17 or inversion 16, any one of them are present, then even if less than 20%, you will make a diagnosis of AML. So if they are not present, any one of these genetics are not present, then look for dysplasia. If it is present, you suspect a MDS, myelodysplastic syndrome. Myelodysplastic syndrome. Yes, blast crisis in CML or MPN will be nothing but diagnosed as AML and treated as AML only. We call it as blast crisis, but treatment will be just like AML. It has progressed to AML basically. Not sudden fever. High grade fever, sudden onset. Gradual onset will be for many months onset, right? Sudden onset or high grade fever. Okay. Yes. On the other side, gradual onset disease manifest usually with cytopenias. They will manifest usually with cytopenias. Could be a MDS or even a MPN. So now if it is a, check for hepatosplenomegaly. If hepatosplenomegaly is there, we will most likely think of a MPN, suggestive of MPN. No hepatosplenomegaly, then most likely a MDS, suggestive of MDS. Although, of course, bone marrow examination has to be done. Bone marrow examination and peripheral blood examination. Peripheral blood examination, if it was a MPN, there will be some cell cytosis, 1 or 2 cell cytosis and other cell cytopenia. Whereas if it is a MDS, all of them cytopenia. So this is how you approach a case of a hematolymphoid neoplasm. So keywords, I told you few of the keywords here. Now other keywords sorry, that you might get is, other keywords you might get is DIC with AML. So AML with DIC, keyword is DIC here, AML, AML M3, AML M3, DIC with AML, AML M3, or translocation 1517 AML. Next, AML with eosinophilia. Very important. AML with eosinophilia will be AML M4 EO. So in version 16.1. Remember, eosinophilia was also seen in LCH, but LCH will present with lytic lesions in the bone, not AML. AML will not present with lytic lesions in the bone. And AML more of adult, not in childhood. And then splenomegaly with pancytopenia. So usually patient having splenomegaly, pancytopenia, and atypical cells in the blood, atypical lymphoid cells in the blood, hairy cell leukemia, suggestive of hairy cell leukemia, suggestive of hairy cell. Yes, MDS can present with either of them because it depends upon how many blasts are there and how dysplasia is there. MDS can present in either. So usually MDS will come as a DD for your AML, not as a CML or myeloproliferative. Mental retardation with AML, mental retardation with AML, start suspecting M7 AML, AML M7. Gum hyperplasia M2 and M4, both of them, M2 and M4, both of them. Most commonly M2, but very commonly, very strong association with M4. Gum hyperplasia M2 and M4, more strongly with M4. So both of them can be the option. So don't expect most common nowadays. So they will give you other hints there. Okay. Yes. So this was about the hematolymphoid. So the last thing I will discuss now is the bleeding disorders. So, bleeding disorders, I will give you quickly. Yes. Bleeding disorders, quick approach to bleeding disorders. Bleeding disorders, whenever patient is having bleeding, look for petechiae purpura present and increase bleeding time. That is one. On the other side is hemarthrosis hematoma, and increased clotting time. So first one is your platelet disorder. The second one is your coagulation disorder, right? First one platelet, second one coagulation. So once it's a platelet disorder, check a platelet count. We already have discussed this partly in the class as well, just to, brush up platelet count. Check platelet count reduced or normal. Platelet count is reduced, then diagnosis is thrombocytopenia. Diagnosis, thrombocytopenia. Thrombocytopenias could be because of DIC or ITP. Very important. In ITP, you will get a history of child having a viral infection. So children, viral infection, they will be giving you ITP. Then TTP, dengue. So TTP also can occur in anyone. More important is in TTP, there can be history of renal failure and even neurological involvement, etc. And other than that, in TTP, there can be abdominal cramps, joint involvement, those things also can happen here. Treatment question will be all the leukemias, lymphomas treatment. We have already discussed them. Gum hypertrophy also seen in AML M3, but M2 and M4 more common. Okay, can be seen, but yes. And TTP, cystiocytes, very important. Peripheral blood will show cystiocytes. Now, normal platelet count could be a vessel wall disorder, which can be a vitamin C deficiency or a vasculitis. Normal platelet count. Or one more will be a functional disorder of platelet. So functional disorder of platelet, then do a platelet aggregation test. Absent aggregation to ristocetin, VWD, or Bernard-Solier syndrome. VWD, Bernard-Solier. Absent to ADP and collagen. Absent to ADP and collagen. Yes, absent ADP and collagen. Glanzmann thrombasthenia, which is associated with LAD. Glanzmann thrombasthenia associated with LAD, type 3 LAD. Platelet granule defect. Platelet granule defect. Chediak-Higashi syndrome. Chediak-Higashi syndrome. Aspirin. Aspirin intake. Next, coagulation disorder. So when you get a coagulation disorder, what do I look at coagulation disorder? Patient is having a coagulation disorder, look for coagulation profile of the patient. Coagulation profile of the patient. In coagulation profile, I'll divide into 4. Only PT elevated, only APTT elevated, only PT elevated, only APTT elevated, both PT and APTT elevated, Both PT and APTT elevated. All normal. All normal. So 4 options. Only PT elevated, only APTT elevated, both PT APTT elevated, all normal. Only PT elevated is extrinsic defect. Only APTT elevated is intrinsic defect. Both PT APTT is common defect or multiple factor defects or multiple factor deficiency. And all normal, only one factor 13 deficiency. All normal, factor 13 deficiency. Now, factor 13 deficiency usually will present with umbilical cord bleeding. That's a manifestation, umbilical cord bleeding. And we'll have, we do a test, urinalysis test there, right? Umbilical cord bleeding, urinalysis test. Only PT elevated. What is only PT elevated? Only PT elevated is factor 7 deficiency. Factor 7 can be a liver disease or a vitamin K deficiency. Vitamin K, 2, 7, 9, 10 are vitamin K dependent factors. Vitamin K deficiency initially will have only PT elevation because factor 7 depletes first. Later both PT and APTT are elevated. And vitamin K is one of the most common cause of increased umbilical cord bleeding. Treatment will be injectable vitamin K. Injectable vitamin K. Now, both PT and APTT elevated, common or multiple factor. Both PT and APTT elevated, common or multiple factor. So do TT there, increased TT or a normal TT. If TT is normal, factor 10 deficiency. TT is normal, factor 10 deficiency. Factor 10 deficiency occurs because of vitamin K deficiency. But TT is also elevated, then there can be reduced platelet count. Yes, sorry, not reduced. If TT is elevated, check for platelet count. It could be reduced or it could be normal. So if platelet count is normal, afibrinogenemia, increase in BT is seen in afibrinogenemia because fibrinogen is required for platelet plug formation. DIC will also have reduced platelet count. We'll have PT, APTT, TT all elevated, reduced platelet count, increased BT. So important, don't look for the wrong keyword. Increase in BT is seen in both DIC as well as afibrinogenemia. Wrong keyword to look at. Examiner will give you those keywords. Don't worry about them. Fibrinogen is reduced in both of them. Do not again look at this. They are not going to differentiate. Platelet count will differentiate. One is reduced, normal platelet count. Another one you can do is D-dimers. D-dimers increased or D-dimers normal. Usually the last one is a very important keyword, but unfortunately examiner will not give you that keyword. Platelet count is the one most important thing. Do not differentiate based on bleeding time, fibrinogen. Both of them are same in DIC and afibrinogenemia, right? Yes. So this is your, both PT and APTT elevated common pathway. The last DD is your only APTT elevation, that is intrinsic pathway. Only APTT is elevated. What do I suspect? Only APTT occurs in a child or in an adult. I look for child or adult. Child mostly I'll suspect inherited, boys or girls. Only in boys, X-linked recessive. That's why 8-9 deficiency. Only in boys, 8-9 deficiency. But however, only in boys you might not get. It could even be other one also. So if it is seen in girl, it cannot be 8 and 9. Then you have to rule out 8-9 VWD, X-linked recessive. And a factor 11 deficiency. Factor 11 is also called hemophilia C, right? Hemophilia C, which is an autosomal recessive disease. VWD is also autosomal recessive, the type 3 VWD. So VWD could occur in both boys and girls, but if boys given, or then don't make a diagnosis of VWD because factor 8 deficiency is more common. That's why we'll make a diagnosis of factor 8. If it is adult, then check whether symptoms are present or absent. Symptoms are present or absent. If symptoms are absent, APLA is one DD. APLA, females with recurrent abortion with thrombosis. That will be the manifestation. Females, recurrent abortion and thrombosis. Factor 11 deficiency. So not 11, 12 deficiency. Factor 12 deficiency. Factor 7 deficiency, as such isolated factor 7 doesn't happen. Vitamin K deficiency, injectable vitamin K. You have to give injectable vitamin K. Factor 12 deficiency. So APLA, factor 12 deficiency, both of them are asymptomatic. No hemarthrosis, no hematoma, but APTT gets elevated. So how will they give you clinically? Classical example. They will give you a patient who has presented to you. You want to do a surgery and you have done an APTT which is elevated. Past surgery, no bleeding manifestation. What do you suspect? Either APLA or factor 12 deficiency. Next. If symptoms are present and it is an adult, we are now suspecting of a factor inhibitor. Factor inhibitors can be seen even in children also, remember. So a child who is getting a repeated infusion of factors like FFP and a cryo can also get inhibitor. Inhibitors are antibodies. For them, you do a mixing studies. So we do a mixing studies. You mix with normal plasma. After mixing with normal plasma, the APTT gets corrected. Yes, for both I told you initially PT elevated, later on both PT and APTT elevated because factor 7 is having a shorter half-life, vitamin K deficiency, 2, 7, 9, 10 are deficient, 7 reduces first, rest all will reduce later. That is why initially PT, later on both PT, APTT. So vitamin K, either they can give you isolated PT elevation or both PT and APTT elevation. For example, a newborn presents to you with increased umbilical cord bleeding, PT is elevated, vitamin K deficiency, both PT, APTT are elevated, vitamin K deficiency. PT, APTT, TT, everything is normal. All tests are normal. Factor 13 deficiency. Yes. So plasma mixing studies, APTT corrects after mixing with normal plasma or does not correct. If it corrects, then it is deficiency. If it doesn't correct, then it is inhibitor. Deficiency and inhibitor. Deficiency, inhibitor. Yes, Divya. So, the 5-day subject, I'm trying to finish it 1.5 hours. That is why. Even factor 13 deficiency, yes, we will see. Very commonly, we see umbilical cord bleeding. Every test will be normal. PT, APT, TT, everything will be normal. Umbilical cord bleeding, other than that, platelet disorders also can manifest, but their BT will be elevated. Okay. Yes. Bleeding time will be elevated there. Okay. Yes. Now, so miscellaneous. Let me talk about few miscellaneous things here. Let me check what miscellaneous I have got. First one is the Newbar chamber. So in the Newbar chamber, look at this. What do I want you to see in Newbar chamber? Where do you count WBCs? In the 4 corner. These blue stained or the light blue stained are your WBCs. And the purple squares I have drawn, 5 of them are for the RBCs and platelets. RBCs and platelets are counted in the same chamber. For dilution, we use a RBC pipette and a WBC pipette. RBC pipette will have a 101 marking, WBC will have a 11 marking. So what is the formula for the count? So just to know this formula for the count, formula for WBC count is 50x per cubic millimeter. So wherever x, what is the x? X is number of WBCs that you count in those chambers. 50x per cubic millimeter. That is the WBC count. RBC count formula is 10 to the power 4x per cubic millimeter. 10 to the power 4x per cubic millimeter. Yes, even in Glanzmann also it can present, but elevated BT will be there in Glanzmann. Umbilical cord bleeding can be there. Next, for platelet count. For platelet count, there are 2 ways to do platelet count. So in platelet count, first initially we end up doing with a RBC pipette. So if done with RBC pipette. See, platelets are always counted in the RBC chamber. If RBC pipette is used, then the dilution will be similar to that of your, yes, dilution will be absolutely similar like of RBC. That is why 10 to the power 4x per cubic millimeter. 10 to the power 4x per cubic millimeter. But however, now very important is if you dilute so much, if your platelet count is low and your multiplication factor is very high, so you will end up getting a very false platelet count. So if platelet count is low, so you will do with WBC pipette. So remember, for platelet count, what do we use? Initially, we use a RBC pipette. If you get a low platelet count, confirm with WBC pipette. So if the count is very low, always, yes, very low with the former method. When I say former, initially you do with RBC pipette, RBC counting chamber. If the count was low, then do not use RBC pipette because RBC is diluting 200 times. Whereas WBC is only diluting 20 times, 10 times lesser. So that is why your results will be more accurate here. Yes, everything will be uploaded. Don't worry. Yes, WBC pipette is used, then 10 to the power 3x per cubic millimeter. 10 to the power 3x per cubic millimeter. Okay. So this is for your different RBC and the WBC count. Quickly in 5 minutes, I'll finish this with just the last point I will discuss will be your keywords for the RBC disorders. So I didn't discuss that. Keywords for the RBC quickly in 5 minutes. Let us finish this. RBC disorder keyword, very, very important is jaundice, dark colored urine, splenomegaly. These are the keywords for RBC disorders. So look for jaundice, dark colored urine, splenomegaly. If any one of them are present, yes, RBC pipette marker will be 101. Maximum marking will be 101. The bead will be red in color. WBC 11 maximum marking, bead will be white in color. So if jaundice, dark urine, splenomegaly present, hemolytic anemia. Hemolytic anemia. More of dark colored urine or more of splenomegaly, then check. If it is dark colored urine, suggestive of intravascular hemolysis. Suggestive of intravascular hemolysis. Splenomegaly suggestive of extravascular hemolysis. X would be number of cells. If it is for WBC, you have to count number of WBCs. If it is RBC, number of RBCs. And if it is platelet, it will be platelet. And in the marked, of course, wherever you have counted, right? Not in all the chambers, in the chambers which are supposed to be counted. So intravascular, very few diseases. PNH is one of them. So what keyword will I look for? Keyword I look for is thrombosis. Pipette, I will show you one. Don't worry. Okay. Yes. Thrombosis and thrombocytopenia. So PNH, usually they'll give thrombosis, maybe a renal vein thrombosis or a Budd-Chiari syndrome, hepatic vein, or thrombus in the brain also. Thrombocytopenia, PNH. Then G6PD deficiency anemia can also be presenting with intravascular. G6PD will have both. So history of oxidative stress will be given to you, and also bite cells can be seen. That will be the keyword there. Then AIHA also can cause intravascular. So for AIHA, history of autoimmune diseases, lymphoma like CLL, or drugs, or Coombs test will be positive. That will be given. Or spherocytes will be given. Or spherocytes will be given. Right? Or spherocytes will be given. Next. So this is, for the intravascular hemolytic anemia. Now next is for the extravascular. For extravascular, the keyword here will be age. Very, very important. Whenever you have a splenomegaly, jaundice, etc. Yes, X would be WBCs or RBCs or platelets in their corresponding chambers. Not in all, of course, wherever you have to count them in those chambers. X will be total number of cells. For WBC, it will be WBC. For RBC, it will be RBC. For platelet, it will be platelet by the extravascular. Age is a very keyword. Child, adult. If it is adult, then you can suspect AIHA. Already I told you what are the keywords for AIHA. G6PD deficiency, although inherited, can present in adulthood. If it is a child, very, very important, age of onset, presenting at birth or after 6 months. If it is at birth, hereditary spherocytosis, G6PD deficiency anemia. At birth, hereditary spherocytosis, G6PD deficiency anemia. After 6 months, so G6PD is very versatile, can present at birth, can present at any age, adults, anywhere. After 6 months, thalassemia or a sickle cell anemia. Thalassemia or sickle cell. So if you are suspecting at birth, then hereditary spherocytosis, what will you look for? Family history. Because it is autosomal dominant disease, family history will be positive. Any one of first degree relative will be positive. Then spherocytes will be seen. And also, spleen can be enlarged. Splenomegaly. Anyway, we'll discuss that. In thalassemia, we don't get a positive family history because it is autosomal recessive, but you're usually seen in closed communities like Punjabis in India, Sindhis, or Mediterranean. So Mediterranean like Italy, Greece, etc. There it is common. In India, we are talking about these Punjabis and in Sindhis common. Then in thalassemia, there will be hemolytic phases seen. Although can be seen in others as well, but very commonly seen in and splenomegaly. Very important in sickle cell anemia, splenomegaly will not be there. So after 6 months, no splenomegaly, then start suspecting of, so splenomegaly, spleen is involved, spleen is not involved in sickle cell. This is how I will differentiate. Now, keywords for nutritional deficiency anemia. Very, very important keywords for nutritional deficiency anemias. This will be the last topic I'll be taking, although, I was allotted only 1 hour, but yes, I've tried to, finish everything here. Nutritional deficiency anemia keywords. Yes, what are the keywords for IDA? What all keywords will you look for IDA? There will be multiple things like celiac disease can be a keyword for IDA. Bleeding per rectum. So that can be either occult bleed or a fresh bleed. So basically polyps or ulcers or carcinoma in the GIT. So elderly patient carcinoma will be there. There can be a young patient who might be having this, all those. Then apart from that, menorrhagia can be also a cause for iron deficiency anemia. So keywords here are these. Of course, other keyword will be microcytic hypochromic anemia. Serum ferritin will be low. Very, very important. Serum ferritin will be low. That is the most important we look for. Look, megaloblastic anemia, nutritional deficiency, megaloblastic. What keyword do I look clinically? Of course, peripheral blood will have MCV increased, all those things we know. Clinically, I will look for atrophic gastritis because it's a part of pernicious anemia. So they would be giving you, patient is having, dyspepsia manifestation for long duration. Now he's having, all of them. Yes, splenomegaly is a keyword. So massive splenomegaly, either thalassemia or a spherocytosis. Of course, fatigue for any anemia, fatigue will be there. Atrophic gastritis, start suspecting of a pernicious megaloblastic B12 deficiency anemia. Apart from this, also ileal disorders. Ileal disorders like tuberculosis or Crohn disease. Very, very important. Crohn disease, they will give you, and don't confuse, any inflammatory bowel disease can have bleeding manifestation. Because it has bleeding manifestation, it can have IDA, and Crohn especially involves the ileum. That is why it can end up having on B12 as well. So if you're suspecting an inflammatory bowel disease having both IDA and B12 deficiency, don't go for ulcerative, go for Crohn. That will be more common, right? Yes, that will be more common. Other than that, autoimmune diseases can be given for megaloblastic because atrophic gastritis is associated with autoimmune diseases. Like they might be giving you a Sjogren's syndrome, or maybe associated with Hashimoto's, commonly Hashimoto, etc. And also in female, atrophic gastritis is very common in female. Other than that, for megaloblastic, few more keywords they might give you: vegetarian or vegan diet. So you might even get this history: vegetarian or vegan, veg or vegan diet. That also can be there. Yes, vegetarian diet or vegan diet. And apart from this, one more: fish tapeworm infestation. Fish tapeworm. Fish tapeworm infestation. So that can also be for a megaloblastic anemia. These are all for B12 deficiency. Other than this, one more very important: anti-cancer therapy. Anti-cancer therapy and also anti-epileptic drugs. Anti-epileptic drugs for folic acid deficiency. These can cause folic acid deficiency. Okay. Yes. So these are, different ways. So basically what I have done here is I've started thinking like an examiner here. So how examiner will end up giving you different clinical scenarios just to twist your, little bit of twists. Do not fall into the wrong keywords that examiner will give. So the idea for the keyword will always be: first look at the last line of the question, look at the option, then you will know you have to differentiate whether between a B12 deficiency or a folic acid deficiency or IDA. Then you will start thinking of, for example, which of the following is the most likely diagnosis? I will give you Crohn disease, ulcerative colitis, and adenomatous polyp and a Peutz-Jeghers polyp. And then, after that, I will end up giving you clinical history where I will show B12 deficiency is also there and iron deficiency is also there. Then do not make a diagnosis of other things. Other will have mostly what? Only iron deficiency, which is your Crohn is the one which will be having, right? Yes. So I hope all of you could now approach with the keywords and picking keywords. There will be wrong keywords, there will be right keywords. So, there is no hard and fast rule. Yes. So you'll have to pick up the keywords. Keyword picking up will happen only once you have looked at the options first. Okay. Yes. So great interacting with you all, guys, and I've tried to cover as much as possible here. Yes, other people, you can look for even DVT, and these two sessions will help you in a different way. Both of them have their own different roles, by the way, right? Yes, all the best. Read notes. So one thing that I have not told you here is treatment for all the leukemia, lymphoma. We have discussed that in the class a number of times. So just go through them, right? Thank you all. Yes. So I will log out now. Thank you all, and let